So thanks again for inviting me, and it's an honor to be here, especially in the Alzheimer auditorium. I'm a geriatric psychiatrist, so when Suryo told me I was going to be talking here, I was very honored, and it's a really great honor to be here. It's a wonderful place, and I'm sure all of you realize that. So as Suryo mentioned, I'm talking about a study that we did at Maryland. It was a small pilot study, basically, that was based on some clinical experience, and I will describe it for you, okay? So I thought it was appropriate to start out with Alzheimer, since this is where we are. And probably a lot of you can pick out Alzheimer in this photograph. Anybody recognize him? So he's this fellow, of course, with the glasses in the back. And with Alzheimer are a number of students. So Alzheimer, as you know, had a laboratory in Munich under Kraepelin, and he had many, many students. And one student, I wasn't aware, studied with him. Anybody notice anybody here related to ECT in the picture? You recognize anybody? I wasn't aware that this doctor studied with Alzheimer, but this fellow right here is Ugo Cerletti. So Ugo Cerletti is usually the person who is described as the founder of ECT, and he was Italian, and he did this in Rome. And Ugo Cerletti, I didn't realize this until just a few weeks ago, studied under Alzheimer in Munich. And there are other people of interest in this photograph. I can maybe just show you that this person is Friedrich Lewy of Lewy body disease and Lewy bodies of Parkinson's disease. There are other famous people in this photograph, but of course, for this talk, I was most interested in Ugo Cerletti. So ECT is a very old procedure as procedures go. 1938, many of you know, it was started in Rome by Ugo Cerletti and Lucio Bini. And the first time it was used in someone who was wandering the train station in Milan. This was somebody who may have had schizophrenia. He had hallucinations. He was delusional. They brought him to the hospital, and this was before review boards and informed consent. So they basically hooked him up to the machine, which you see here. This machine is in the museum in Rome. They hooked him up to this machine, gave him bitemporal ECT, 11 treatments, and he made more sense after that. And they thought that was successful. And that's where it all started, 1938. So people have been practicing ECT since then. There have been refinements, as you know. We use anesthesia now. This person didn't benefit from anesthesia. We use neuromuscular blockers, so people don't actually have full convulsions. So the early treatment was actually, pretty basic, and people had more complications. And we've come a long way since. So I'm going to talk to you a little bit about why I did this study. I've been doing ECT now for 25 years. I started as a medical student, and then as a trainee, and then now I do ECT as a psychiatrist. And all those years, I've been causing people to have seizures, and people get better. And I think it's a very good treatment for depression and other disorders, but it has some side effects. The worst side effects usually are cognitive side effects, so people have memory problems. The memory problems are usually temporary, but they can be very disturbing, and if people have jobs that require lots of thinking and memory, it can disrupt their lives. So it's a good treatment, but it does have side effects. And because of these side effects, there are many people out there who might benefit from the treatment, who have, say, depression and are suicidal, and they're not getting better with medicines, but they refuse the treatment because they're worried about what it might do to their memory. And some of these people go on to commit suicide. So the rationale then behind trying to come up with it, perhaps a treatment with less side effects, is that more people will be able to take it. If we can get a treatment that is just as effective with fewer side effects, then more people will be happy to take it. So the hypothesis for the study was that one could give electrical brain stimulation applied just like standard ECT with a regular ECT machine, but below the seizure threshold, and that can have therapeutic effects that are like the effects of ECT on major depression, but with fewer adverse cognitive effects, so with less effects on memory. That was the idea. So why would I think that I could do this? Why would I even, I've been taught for many years you have to have a seizure. I've been causing seizures for 25 years. At that point, I guess for a little over 20 years. And why would I think that I didn't need to cause a seizure? So these are the reasons. So the first reasons really were that I had two patients who I could not cause a seizure in, two patients who had ECT, but one I could only cause one seizure, and the other I could not cause any seizures in. So how many people here have done ECT? I know you mentioned one, and right? So have you had patients you could not cause seizures in? No, never, never? Okay. So these are very few patients, very few people. I would say it's maybe, in my experience, it's more like 1 out of 300 people. You raise the energy all the way up in the machine, you can't get a seizure, you try using other anesthetics that might make it easier to have a seizure, but still you can't cause a seizure. So I had a couple of patients like this, and I kept trying different things to cause a seizure, and still I couldn't get a seizure. But what I noticed is that they did get better. I was surprised by that, but I saw them getting better after they had 2 or 3 or 4 treatments, so I continued. And I gave them the treatments and did not cause a seizure. One had 5 treatments, the other had 8 treatments, and they both were better. Now I thought this could be completely coincidence. It may not have nothing to do with what I'm doing, but they really weren't on aggressive medication treatment at the time, so I did not have another explanation other than maybe the electricity was helpful. So another reason to think maybe you can improve mood without seizures was that, as you know, repetitive transcranial magnetic stimulation has been approved. It was approved in the United States, and it's approved here for treatment-resistant depression. And in that treatment, you are given, there's an electric current created by a magnetic field, and it does not cause a seizure, but there's evidence that it improves people's mood and depression. So this is other reason to think that maybe we don't have to cause a seizure. Other reasons are, I looked into the literature going back into the 40s and the 50s, and you see that people around the 40s and the 50s, soon after ECT came out, they started experimenting with this a little bit. They thought, well, let's see if we bring the current down, maybe we can make improvements without causing the cognitive side effects. So people had this idea well before me, but when I looked at this literature, there weren't any really good studies that I could look at and say, okay, that definitely this works. Some of the studies said it worked, some studies said it didn't work. The way people talked about psychiatric disease back then was a bit different. They didn't have the DSM where we have these, diagnostic guidelines. So that literature was helpful to me and provided some rationale, but it wasn't convincing that it was either helpful or not helpful. And then there was some reports in the ECT literature that when you give stimulation on the first treatment, when you're trying to find somebody's seizure threshold, many times you don't cause a seizure in that first treatment. And in those treatments, people did some studies and realized it looked like they weren't causing any problems with memory when they had those treatments. They weren't causing any problems with cognition with that first treatment. So the first treatment, many times with ECT, you titrate the energy to find the seizure threshold, and there was at least one paper published showing that that did not cause problems in cognition. So I thought, maybe if we don't cause a seizure, maybe we won't cause problems in cognition. So another thing to point out is that when Cerletti and Bini did their first ECT, the whole history of this was using convulsions to treat mental illness. It was not using electricity. So what Cerletti did was, he was the first person to use electricity. Before that, it was always using proconvulsive drugs, and this had its own problems. And so really what Cerletti did was cause the electricity to be used, and ever since that happened, there's always been the question, how important is the electricity and how important is the seizure to the benefit and also to the side effects? So I thought about these two patients, and I didn't initially just start the study. I knew it was going to be risky to do something like this. I might have patients who really needed treatment, and yet I was going to give them something that wouldn't work. It might delay their treatment. It might cause side effects that I wasn't aware of. So I was a little bit anxious about doing this, I must say. When you grow up in your career and people tell you have to have a seizure, and then you start thinking maybe you don't, it's something that you think about before you just jump into. So I gave it some thought, realized it was a bit risky, and this is a joke from The Far Side. Everybody familiar with The Far Side? So the punchline here is, that's why I never walk in front. So I didn't want to end up like this fellow in the cartoon, you know, where you do something that other people aren't doing, you're out in front, and then it goes badly, and, you know, your career isn't so good after that. So I was, like I said, I was a little anxious about it, but I went ahead anyway. So I'll tell you a bit about the study, about what the methods were. So it was a small study. Only 13 individuals with major depressive disorder participated in the study. These were 6 people with unipolar, 7 people with bipolar depression. It was an open label study, so there was no blinding. I knew everybody was getting nonconvulsive therapy. There was no sham control. And it was an adjunctive study. So everybody except one person was on medication for depression, bipolar disorder. So these people were on multiple medications. So it was what we call an adjunctive study. It was done between 2010 and 2014, and it was approved by our institutional review board, which is our ethics review board. Everybody was an adult. Everybody was an outpatient. There were no inpatients. It would have been too expensive to do this study in the United States with inpatients because it's very expensive to have people in the hospital. Everybody had a diagnostic interview to establish their diagnosis as either major depressive disorder, unipolar, or bipolar. They all had to have a Hamilton depression score, that's a 17-item scale score of 16 or better. So these were people with moderate depression or worse. So the other thing that the ethics board wanted me to do was to make sure that everybody who participated in the study had refused ECT. They didn't want people in this study who were willing to have ECT, because we know ECT works. We know this may or may not work. So they wanted to make sure that anybody in the study said, I do not want ECT. So either they'd had ECT before and they didn't like the effects, or they just decided, I don't want it because they're worried about the memory problems. So as I mentioned, everybody except one person in this study was on medication. That is a confound. And so the best thing one can do is to try to make sure the medicines stay steady during the treatment. So for a month prior to the treatment and then during the study, nobody could change their medicine. If they wanted to change the medicine, they have to come out of the study. So we keep that constant. In terms of how long the study lasted, it really depended on how people did. And this is kind of how we do it in regular clinical practice. For ethical reasons, if people did not have a 25% or better decrease in their depression scale score at treatment 4, I took them out of the study. And again, that's for ethical reasons, because most people getting ECT will start to get better after the 4th treatment, by the 4th treatment. And so I was afraid of keeping people in the study for too long. So if they didn't get better by the 4th treatment, I took them out. If they continued to get better, we kept giving treatments. If they stopped getting better for at least 2 treatments, then we would stop the treatment. And that's pretty much what we do with ECT. If people get better, but then they plateau and they stop getting better, we usually will stop the treatments. And that's what we did. So in terms of how I put the electrodes on, with ECT, as many of you know, some of you don't, but the original way of doing it, the way Ugo Cerletti did it and others, is to put the electrodes here bitemporally. It's a very effective way of treatment. You probably get the fastest response, but it also causes the most problems with cognition. So when you put the electrodes here, the thought is the current goes through the temporal lobes. The temporal lobes are very important for memory. And the thought is that you're disrupting memory most by putting the electrodes here. The other popular ways of doing it are what we call right unilateral, where you put one electrode here, one here. And then the way that we typically do it at Maryland and some other places do it is we put the electrodes bifrontally right here. So with the 2 patients that I had who got better without having the seizure, the 2 ECT patients, we were using the bifrontal placement. And so I used the bifrontal placement in the study, and that is this placement right here. This is what we used. Electrode here and electrode here. And we use the standard ECT machine. There are a couple of standard ECT machines in the United States. We used the most commonly used one, which is the Thymatron System 4. We used a brief pulse, which is 0.5 milliseconds, which is pretty standard. And we had the machine modified because the standard machine only goes down to 5 joules in the terms of the total energy it gives. But we needed to go down lower than that, so we had it modified so it would go down to 1 joule and then 1 joule increments. The normal machine goes 5 joules, 10 joules, 15 joules, but ours went down to 1 joule. And if you have questions as I go through this, if something doesn't make sense, feel free to raise your hand, by the way. So one difficulty with the study was how much energy do I give? I don't want to cause a seizure, but I do want to give enough energy to get the electricity to the brain and to make people better, I hope. With the people who couldn't have a seizure, I was giving them the maximum amount of energy on the machine, which is 100 joules. So I couldn't do that with these people. They'd all have seizures. So I didn't know where to start. So there is one, what we call rule of thumb in ECT, where setting the threshold is half the person's age. It's a very rough way of doing it, but I thought, okay, I will cut it in half from there. So instead of giving 30 joules for somebody who's 60 years old, I'll give 15 joules. I'll cut it in half. The problem with that was people had seizures at that. And so I cut it in half again. People still had seizures. And so I wound up cutting it down to 1/16 the age. So this is 1/8 of the normal amount of energy we'd give with ECT. So if somebody were getting ECT, I would be giving them 8 times the amount of energy I would give in this study. And at that level, people did not have seizures. So how did I look at whether they were having seizures or not? I used the same method that we use in clinical ECT, which is a pretty simple method. Perhaps I could have used a more complicated one, but what I did use was as those of you who do ECT know, we will inflate a cuff in the arm, make a tourniquet out of it, so that when we give the intravenous neuromuscular blocker, succinylcholine, it doesn't get to that arm. And so we can watch to see if there are tonic-clonic movements in the arm. And that's how we show whether they have a seizure or not. So we looked at that to see if they're having seizures. The other way is we had a simple 2-lead EEG with a lead here and a lead here. And that gives you an EEG output. And we look for there to see if they're having seizure activity. So on that basis, we notice whether they're having seizures or not. And then the anesthesia we used was the same anesthesia we use with ECT. Exact same thing. So we give methotrexate, which is a barbiturate anesthesia, and then we give a neuromuscular blocker, succinylcholine. Same thing. The reason why I did that is because they still might have a seizure. And if they have a seizure, I don't want them to have these convulsions, so we give the neuromuscular blocker. Occasionally, we would give other medicines like ketorolac in case people had headaches, or we would give beta blockers, beta adrenergic blockers, if people's heart rate or blood pressure went up. These are all standard things with ECT. So how did we decide if people were getting better? We used standard outcome measures. We used, like I mentioned before, the Hamilton Depression Rating Scale. It's probably the most commonly used one. We used the MiniMental State exam, which is often used clinically. We used the autobiographical memory inventory. So the autobiographical memory inventory looks at retrograde memory impairment, which is affected by ECT. And the MiniMental is, are you familiar with the MiniMental State? It's a simple global approach to looking at cognition. And then also looked at reorientation time right after the procedure. So how long did it take for somebody to be oriented to who they are and where they are after they have the stimulation. And then for data analysis, I got analyzable data from 11 out of the 13 participants. 2 people had seizures on their first treatment, and so we didn't have any seizure-free data. 1 person had a seizure on the 5th treatment, so I used data from the first 4 treatments. And we did some very basic statistics using 2-tailed paired T-tests to look at the Hamilton Depression and the MiniMental State scores. The other thing we looked at was the percent correct on the autobiographical memory test. So with that, you ask people questions about autobiographical things like a family member. Tell me about somebody in your family who's close to you. What's their name? What's their address? What's their phone number? And now with people having cell phones, nobody knows cell phone numbers. It's very interesting. So you ask them, okay, what's their phone number? And they go, I don't know their phone number. It's in my phone, you know. But usually they know their address. They can tell you who they live with. And then you ask them questions like, what did you do on your last birthday? What did you do on New Year's? When was your last visit to the doctor and what was it for? So these are things about their life. You ask them before the study and then after, and you see if they give you the same answers. That's how you do that. Any questions about methods before I go on? Any questions about that? Okay, drink of water.
Did you use an anesthesia?
So, we use methotrexate. What do you use here for anesthesia? Which? Etomidata. Yeah, okay. So etomidata. We will use etomidata when we can't get a seizure, because etomidata is very good, better in terms of seizure threshold. So those patients, the 2 patients I told you about, we tried etomidata. Even with etomidata, we still couldn't get a seizure. So our standard is the barbiturate methotrexate. That's what we use in the U.S. And then we use succinylcholine. You use succinylcholine? Yeah. Any other questions?
The decision about the dose was done in a pilot study, or was this because you couldn't include those patients who actually had seizures?
Right. So the whole thing was a pilot study. And so, you know, what I had to modify my protocol. So my initial protocol said, I'm giving you half half of what I expect. People had seizures. I had to keep modifying my protocol. I keep going back to the review board and say, I have to change the energy, I have to bring it down. Of course, the review board was okay with that usually because I wasn't bringing the energy up, I was bringing the energy down. So that's usually okay. But yeah, I couldn't, the dose finding is definitely an important issue. And we maybe talk about it in the discussion a little bit. So the results, here are the baseline characteristics of people in the study. Average person was an adult, sort of young to middle age, about almost 40 years old. Slightly more women than men. We have 7 Caucasians and 4 African American participants. These were people who were pretty educated. So the average years of education was 15 years. So I had people in this study who were psychologists. I had people who were informatics specialists. These were educated, fairly educated people, many of whom had jobs, who were afraid that, and a couple had ECT before, and then they tried to go back to their job doing computer science, and they couldn't remember things so well. So some of these people had jobs and had jobs that involved memory, and they were concerned they didn't want to have ECT again, or they never wanted to have it, period. Diagnosis, again, slightly more bipolar than unipolar depression. We had 17% had a family history of mood disorder. Actually, yeah, so age at onset, around 17 years. So these are people who had depression for a long time. Average person, they started with depression at age 17. So pretty long histories of depression. I think I mentioned prior ECT. 2 people had prior ECT. For both, ECT worked for them. It worked for them, but they didn't like the effects on the cognition. 2 people had RTMS, the repetitive transcranial magnetic stimulation, and unfortunately the RTMS did not work for them. The average episode duration was 25 months. So these people, on average, had been depressed for 2 years when they came into this study. They'd had 2 years of depression without getting any better, despite medication. And they'd had on average 4.5 medication trials. So these people had 4 to 5 different medications that they were tried on before they came to this study. So these are all people with what we call treatment-resistant depression. These aren't people where you give the medicine and they get better. These are people you give one medicine, you give another medicine, you give another medicine, and they're still not better. So this slide has sort of the ultimate results of who got better and who did not get better. And what you can see here is, here's the baseline Hamilton Depression Score. So here's baseline. People start anywhere between 25 and 16. Here is the score after 4 treatments. Here is the score at the end of the course. Now, the end of the course varies from participant to participant. Some people had 8 treatments, some people had 10 treatments, some people had less. There were 3 people who didn't get any better at all. So this is one person here. These are 2 people right here. So these 2 people, they started at a Hamilton Depression Score of 17, and then after 4 treatments, they were no better. The score was still 17. This person started at 20, after 4 treatments, still 20. So all these people were withdrawn from the study as non-responders, because I decided that if they're no better after 4 treatments, we take them out of the study, give them the opportunity to have ECT or to have more medication changes. So, and then most people, so 8 out of 11 people did respond. And you see that comes down here, and then some of them get a little bit better after 4 treatments. Some of them stay about the same. And if you do the Ttest, you get a significant difference between the start and the 4 treatments and the start and the end. And this table talks a little bit more about the results. So the average number of treatments people got was around 7. This is the number of treatments here. The mean was around 7 treatments. Responders, people who got better, had averaged almost 8 treatments. That's actually the number that we most commonly have clinically in ECT. Our average number, if we do ECT, our average number is 8 treatments for people to get better with depression. I don't know, what do you do here? About the same, yeah. And then the non-responders, they were all people who got no better, and then we took them out at 4 treatments. So their average number was 4 treatments. So again, for people who got better, average 8 treatments. How much stimulus did we give them? On average, it was 2.6 joules, which comes out to 13.3 millicoulombs. This is how much energy was given. And then in terms of the change in the scores, the average beginning score, the average beginning score was a Hamilton depression score right around 20. And then on average, it dropped down to 8.6. So the average person had a 55% drop in the Hamilton depression score. In terms of remission and response, it's customary to define response as a 50% decrease in Hamilton depression score. Remission definition varies. So the way we defined it and the way some other people do is you have to have at least a 50% drop, and then your Hamilton depression score has to be below 8. So we had 55% of people who responded, and 73% of people who responded, that's 8 out of 11, and 55% who had remission, which is, remission, of course, means that most of the symptoms went away. And then we had a reorientation time of around 6 minutes. What that means is we give the stimulus, and then we see when the person wakes up from the anesthesia, and we ask them questions. What's your name? What's the year? When were you born? What's the name of this hospital? What's the name of this city? We asked them 9 questions, and on average, it was 6 minutes until after the stimulus for them to answer those questions correctly. Then the MiniMental State score, average, it started out at 28 points, and it actually went up at the end of the treatments to around 29 points. So there was no decrease in the MiniMental, which is you usually see a decrease with ECT. In this case, we saw a very slight, insignificant increase. I keep doing that. And then in terms of the autobiographical memory, when we looked at people's answers before the treatment and then we looked after, they were 97% correct, which is pretty good. So if I asked them, who's your family member, who do they live with, what's their address, or I asked them, what did you do on your birthday, they got 97% correct answers after the treatment. They gave me the same answer 97% of the time. And then another thing we did as a biomarker was to look at BDNF plasma levels. So some groups, including our group, has looked at BDNF levels with ECT. Some groups have found them to go up with ECT, some have not. So I looked at this to see, I was curious, is this going to change the BDNF plasma levels? And so it did not. The plasma level, I keep doing this, sorry. Apologize. Okay, so the plasma level, as you can see there, went up slightly, but this was not significant because the variation was so great in between people that the slight, 30-point difference is not significant. Any questions about any of that? Okay. Okay, now in terms of adverse effects, what bad things happen to people? There were no serious adverse effects. So we usually define serious ones as death or any harm that causes hospitalization or any harm that is permanent. So no one had that kind of serious adverse event. There were some adverse events that people had, and I list them here. We had 3 people that I caused the seizure in, so that's an adverse event because I wasn't trying not to cause a seizure. We had 3 people having headaches. We had fatigue. We had some jaw pain. We had 1 cardiac arrhythmia. This is my first patient. You know, how many people have done clinical research with patients here? How many people have done clinical research? So, yeah. So, as you know, it can start off badly. So my first participant, not only did I cause a seizure, but he went into ventricular tachycardia. Very briefly, but he did. And so, you know, we gave him some beta blocker and it went down. But you can imagine this is my first participant. Not only did I cause a seizure, but he goes into ventricular tachycardia. Briefly, but, you know, this was not a good start. So that was my one you know, scary moment. We had somebody have an anxiety dream. We had some dizziness and we had some sore throat. Now, some of these could have been due to the anesthesia. Some of them could have been due to the stimulus. When we give the stimulus, we do stimulate the muscles here. So people do clamp down. Like with ECT, you have to use the bite blocks, and people can get the kind of jaw pain that people get with ECT. So any questions about adverse events? I'll get another drink of water. Okay. So then, in terms of discussion, I'll first talk about how do the study results compare to regular ECT. So what I thought I would do is try to compare them to bifrontal ECT. So ECT where you have the electrodes here, because that would be the best comparison. And luckily, there was a pretty recent study done that was published in the British Journal of Psychiatry where they compared 3 different electrode placements, the right unilateral, the bitemporal, and the bifrontal. And they did really pretty good. This was a good study. It was randomized, a controlled study, and they looked at effects on cognition. So it was helpful in terms of comparison. So if I compare what we found, which is the net, so here is nonconvulsive electrotherapy, here is the bifrontal ECT. What you see with the net is our percent change in the Hamilton Depression Score was 55%. The bifrontal ECT had a 67% drop, so it was better than ours, in the same, what we say in the United States, ballpark, but the bifrontal was a bit better, bifrontal ECT. In terms of remission rate, they defined it slightly differently than ours. They used a 24-item Hamilton depression, and they said we want to have a 60% decrease and a score less than 10. Their remission rate and our remission rate was similar. Their remission rate was a little higher than ours. Theirs was 60.5%, ours was 55%. And then if you look at the adverse effects, if you look at their MiniMental State, they had the typical decrease in MiniMental score. So they had a 1.6 point drop, whereas we had a 0.9 point increase. And then if you look at their retrograde memory score, the AMI-SF, at the end of their study, people only answered 58% correctly. Ours, we answered 97% correctly. So from this, I conclude that in terms of the benefits for depression, they're similar. I think the bifrontal ECT is a little better. You know, maybe that's significant, maybe it isn't. If I look at the effects on cognition, clearly what we did caused less problems with cognition. So the MiniMental State score did not go down, and people remembered correctly almost all the time with the retrograde memory test. In terms of reorientation Post-procedure, you see a big difference here. So with bifrontal ECT, they asked people reorientation questions 20 minutes after the seizure, okay? We looked at people, on average, it was 6 minutes. At 20 minutes of bifrontal ECT, they answered 4.8 questions correctly out of 10. So they got about 50% correct at 20 minutes, whereas with the nonconvulsive electrotherapy, people had 100% correct at 6 minutes. So very big difference if you have a seizure or you don't have a seizure. If you don't have a seizure, you're just dealing with the effects of probably the anesthesia, and for that effect. But with a seizure, people have temporarily a very strong disorientation, and that's what you see here, the difference. In terms of the plasma BDNF level, we did not, as I mentioned before, we did not see a significant change in the plasma BDNF level in our patients, in our participants. Now, study limitations. As you can imagine, this study is a pilot proof of concept study, had a lot of limitations, and I want to mention them now. So again, it was a small study. We had usable data from only 11 people. It was unblinded, non-randomized, uncontrolled by a sham procedure. Therefore, the results are susceptible to both investigator bias, my own bias, and also the bias of the participants. And so any results here really are preliminary results. We can't consider them definitive results. Almost everybody, except for one person, was taking medication during this study. And even though we kept the medications even, there's still some possibility there could have been a medication effect. I cannot rule that out. Other limitations, as you know, people who do ECT, many of these people are seriously ill, have very, very severe depression. Some of them are psychotic. In fact, the data suggests that if you're psychotic, you actually respond better to ECT. So these were people who did not suffer the highest degree of depression. Therefore, it's possible that they were more prone to a placebo effect. Maybe because they weren't quite as sick, they might have benefited more by a placebo effect. Also, everybody had anesthesia. I cannot rule out that some of this might have been an effective anesthesia. There's no way that I can rule that out. We did not have a control where people just got anesthesia. The other thing is we only use the left unilateral EEG to monitor for seizures. So it is possible that we did not pick up seizures in some of these patients. They wouldn't have been grand mal seizures, but maybe they could have had some focal seizures we didn't pick up. It's possible. But as you know, with ECT, the theory is you have to have a generalized tonic-clonic grand mal seizure. So I can definitely say no one had anything like that. It is possible they might have had focal seizures that we did not pick up. Another thing is, as you know, we use fairly simple cognitive tests. The MiniMental State is a fairly quick and simple cognitive test. It's not very sensitive. If we would have used more sensitive tests of cognition, we might have seen people have a decrease in their cognition. So it's still possible that people had some decrease in cognition that we didn't pick up. Another issue is, as I mentioned before, the people who did not get better after 4 treatments, I took them out of the study. It's possible that some of those people might have eventually gotten better with the treatment. We do see in ECT some people respond late, but for safety reasons, that's what I did. But that may have affected the results as well. Also, these were very treatment-resistant patients. And so it's possible that if I'd used people who weren't treatment resistant, I might have had better response rates. I don't know. But so the response rate in this study might have been lower than, say, the people used in the bifrontal ECT study, partly because I was using treatment resistant people. Maybe, maybe not. So any questions on limitations? All right. So lastly, I'll talk a little bit about mechanism, because this is, what I think is perhaps most interesting about the study. is that if the stimulation was helpful, if it wasn't all a placebo response, how could it have worked for people? How could the electrical stimulation have worked without inducing a seizure? And hasn't it already been proven that you absolutely have to have a seizure if you're giving stimulation in the manner of ECT? Isn't it already proven that you have to do that? And this is something that when I started doing the study, of course, I looked into, I read a lot about. I had made the assumption, of course, that you do have to have a seizure. This is what I was taught for all those years. And then when I looked at all the studies and I talked to some of the experts, I realized that there was not definitive evidence for it. In my opinion, there's not definitive evidence. The evidence base that shows that ECT works is based on studies, good studies, where they compared ECT, regular ECT, to just anesthesia. But in none of those studies did they have a component where they gave electrical stimulation that was clearly stimulating the brain, but was not causing seizures. There are just no published studies like that. And so because of that, because they didn't have that kind of control, it's hard to definitively say you absolutely have to have a seizure. Now, there is some evidence suggesting that you have to have a seizure, and I'll briefly talk about that. So the first studies that suggested, yes, a seizure is necessary were done in Denmark by Kronholm and Ottesen, and basically what they did there was they gave lidocaine to a group of patients, and it brought the seizure it raised the seizure threshold, and they had seizures that lasted not as long. The duration of the seizure was not as long as the people who didn't get lidocaine, and they did not get as well as the patients who did not get lidocaine. So they concluded that seizure duration is important to the therapeutic effect of ECT, and therefore a seizure is essential. Well, what's interesting is that there have been many attempts to duplicate that research over the years, and most studies do not duplicate that. Most studies find that duration is not directly related to the therapeutic effect of ECT. So in that sense, it's not excellent proof that a seizure is necessary. So again, as I just mentioned with here, duration is not a reliable predictor of the therapeutic effect of ECT. If you look at how long somebody seized, it doesn't necessarily predict whether they got better or not. There have been other studies looking at the other features of the EEG. So you can look at duration, but you can also look at EEG features and say, do any of these EEG features predict response to ECT? And there have been some good studies. And some of these studies have suggested that, see, I'm not sure I have this here, but yeah, okay. Some of the studies suggest that if you give ECT and you get post-ictal suppression of the EEG waveform, so the person has the seizure and then after the seizure you have no electrical activity, you have this bioelectric silence, that predicts response. And there's some good papers on that. And if there's any EEG predictor of response, it's probably that, this post-ictal suppression. But there has been at least one study that suggests that that is not a good predictor of response. So there was a study done by Pereira et al., by a very large group in the United States at Columbia University, where they noticed that they had different types of right unilateral ECT, where it was very effective, and yet it would not cause this post-ictal suppression, even though it was effective. So again, you wonder whether this really is predicting response. And the Pereira group thinks actually that the EEG features have less to do with how effective the treatment is and more to do with the actual brain of the participant. That people who are going to respond to ECT have brains such that if you give them a seizure, they're more likely to have this post-ictal suppression. But it's not a marker of treatment efficacy. It's a marker of the participants' neurophysiology. That's what they think. So again, this is controversial. I'm just kind of laying it out for you. So possibly there are some biomarkers that might be helpful in selecting people, I'm thinking, both for ECT and also for this treatment. And maybe in future we can come up with these and try to see if we can come up with markers of what is an effective treatment and what is not an effective treatment. And this can be helpful in doing research. So I'll just conclude. So the results of, I think the results of this small open label proof of concept study suggest that non-convulsive treatment administered with bifrontal placement has an antidepressant effect. It suggests that for treatment-resistant depression. This finding challenges the widely held belief that a seizure is necessary for the therapeutic efficacy of electrical brain stimulation administered in the manner of ECT. That the non-convulsive treatment was relatively safe without serious adverse events or adverse cognitive effects that you typically see with ECT. However, given the limits of the study, and there are lots of limits of this study, further investigation is needed to conclusively determine the efficacy and safety of non-convulsive electrotherapy. And that a comparative study between non-convulsive therapy and electroconvulsive therapy may be indicated to assess the relative risks and the benefits in individuals with treatment-resistant depression. So if we took people and randomized them to regular electroconvulsive therapy and non-convulsive, of course this would be the best study, and that would be the best way of showing this. I had some references, and I also wanted to acknowledge my collaborators in anesthesia, Robert Narani, who was very helpful, and with whom I could not have done this study, as well Deborah Piez and Palak Patel, who were very helpful in the study as well in working with the participants. And of course my funding source, which is really a great source of funding, the Brain and Behavior Research Foundation, formerly NARSAD. They funded this through an independent investigator grant. The National Institute of Mental Health was not interested in the study initially. I think it's too risky for them, and foundations like this are very helpful in funding these sort of high-risk studies. So with that, I'll just say, again, thank you very much for your attention. I apologize for my not speaking German. Thank you for your patience, and I'm open to your questions. Thank you. Thank you.